Okay, so let's start off with the oxygen or airway in our review. SpO2, partial pressure of oxygen in the capillary bed. Remember, it's the little finger probe that goes on the end. It measures the partial pressure of oxygen in that capillary bed. Things will affect the SpO2 or pulse oximetry or pulse ox. It's known as quite a few. Cold hands, like I have right now, will affect the pulse oximetry. Fingernail polish, diabetes, things that causes vasoconstriction is going to shock, will affect the SpO2. Okay, so but we try to get the SpO2, the partial pressure of oxygen. You note the slang terms in it as the percent of oxygen in your blood, right? Saturation of oxygen in your blood, and that's sort of correct. That's the easier way to understand it. Okay, even though it's a partial pressure, we want to get a SpO2 prior to administering oxygen. We want a room air SpO2 because this gives us a baseline. Without that, we have no baseline if or when we apply oxygen. So we want to make sure that we get a room air SpO2. The normal is 95 to 100%. Anything below 94%, this is where we start into this evaluate the need for oxygen. Prior to about 2000, before you guys were born, okay, everybody got oxygen. It didn't matter. You guys stub toe, they put oxygen on you, okay? If you get really bored in life and you want to read about why they changed this, it's because of the free radical ions that oxygen causes and damages tissue. So at about 2000, the year 2000, okay, seems so long ago, we started evaluating the need for oxygen. So if the patient has an SpO2 below 94%, and has outward respiratory distress or complains of shortness of breath or respiratory problems, then we would more than likely apply oxygen. When we look at this and we're sitting there and we're evaluating this need and we just apply oxygen, even in a heart attack or a stroke or trauma, it can still have a negative effect on tissue at the cellular level if they don't need oxygen. So at some point in your healthcare path, you'll have a class on these free radical ions. I just don't want to do it to you. I'll let someone else abuse you with that, okay? Anyhow, so we're going to evaluate the need for oxygen and get a room air SpO2. When we look at oxygen delivery, the first thing that we have to do is to identify the oxygen cylinder. So remember, we identify it three ways. One way is through the color. It's either completely green or green and silver like this one, okay? If this was a real tank with oxygen in it, it would have a label on it that says oxygen. It would have one that says USP, oxygen. US pharmacopoeia means it's a drug. Okay, it's a medication. And so it have a label. And then the last thing to do, it has a 2-pin index system on the oxygen cylinder. This particular oxygen cylinder, okay, it's a D cylinder, one that's portable. You have the long skinny ones, which are E, and the big H cylinders that are usually stuck behind the wall or something. But you have this 2-pin system there on the oxygen cylinder on the neck. This is only for medical grade oxygen. We use oxygen for other things like welding and different things of that nature, but this is for medical grade oxygen. It's drier. Okay. So we have that 2-pin index system. So we have the color, okay, the label, and the 2-pin index system, which matches up with the regulator, the 2 pins on the regulator. Try to float that in there. Okay. What the regulator does is it regulates this oxygen coming out of the cylinder at 3,000 psi, pounds per square inch. So oxygen is measured in pounds per square inch, and it regulates it down to something that's breathable. That's a word. Okay. And it does it by this large spring in the regulator. And then on the regulator itself, there's a large spring in here that compresses and makes the air where the patient can actually breathe it. You have the liter flow on one side, and then you have the gauge that tells you how much oxygen is in the cylinder. There's a red mark that says refill. That's your residual volume. So for sure, before you put it like a non-rebreather on somebody, you'd want to make sure that you have enough oxygen in there. When it's at 500 psi, so the non-rebreather will be use that oxygen up really quick. And so you want to make sure that you have plenty of oxygen in your cylinder if you're using it as portable. Oxygen is measured in liters per minute. So when, just like any medication, we have a indication, a contraindication, and then we have
teachers. We're going to do a dress code sweep right now. We're going to do a dress code sweep. Look around your room, and if you see any students that are out of dress code, what we're looking for is if they're wearing jeans, inappropriate top, which does not match our dress code. So we're doing a dress code sweep right now. And we will send those students down to the front office area, down to the cafeteria area, to see if anybody has a dress code violation. If they're wearing short skirts,
pretty sure they know
jogging pants, sweat, any of those things that are not part of our dress code, if you send those students down to the office area, and back to class. Thank you.
okay, great interruption. Wow. So we have different devices that allow us to deliver the oxygen at certain liters per minute, but what we have is the dose essentially for oxygen is measured in liters per minute. Now what we're trying to do with supplemental oxygen, because remember we breathe oxygen now, correct? What percent are we breathing now in room air? 21. So we're breathing 21% room air. Percent or fraction, remember the FiO2, fraction of inspired oxygen, FiO2. So our fraction of inspired oxygen, or FiO2, right now, without supplemental oxygen, is 21%. So when we give a patient oxygen, we're adding to that percentage, okay? So the first one that we look at is a nasal cannula. It's the one that has the nasal prongs in it, okay? The nasal prongs go in the nose, then it loops back over the ear, okay? The dose for the nasal cannula is 2 to 6 liters per minute. In practical medicine, about 4 liters is about all that you want to put a nasal cannula, because it's really dry and it gets uncomfortable, all that air blowing up somebody's nose, okay? But the books do say 2 to 6 liters per minute. It increases the FiO2, fraction of inspired oxygen, from 21% on room air to 24 to 40%, somewhere in there. There's such a big variety of percent between that because you're breathing in mixed gases. So you're breathing in carbon dioxide. So you mix these gases together, okay? Anyhow, the indication, because like with any medication that we give, we have to have an indication. So the indication for a nasal cannula is mild respiratory distress. So you have someone there, maybe they're breathing a little fast, they're still breathing through their nose, they're not mouth breathing yet, so they're breathing through their nose, okay? Maybe their rate's up a little bit, okay? Something of that nature, but they're just real mild respiratory distress. So if you were to, like on a scale of 1 to 10, if you were to judge it that way, this person would be like a 2 or a 3. Or maybe they're having 4 or 5 word dyspnea, where they're having to take a breath every 4 or 5 words. That's sort of mild. Severe dyspnea would be one word dyspnea. Means they have to take a breath every word, right? And so the nasal cannula is widely used for mild respiratory distress. The simple face mask is not that used anymore just because of economics. It's used more in pediatric patients. It will increase the FiO2 to 44 to 60%. So it's good, but it's still, because of this gap here of the percentage, the patient is breathing in and out carbon dioxide. So they're mixing oxygen and carbon dioxide together, mixing those gases, which lowers the percent of oxygen. The dose, or the liter flow, is 6 to 10. That almost looks like 101, but it's 6 to 10 liters per minute on the simple face mask. Usually around 6. So you have a variety. Now keep in mind, when you're doing your assessments, okay, 1 liter of change in oxygen won't do anything. Okay? So if you're having a patient that has, some trouble breathing, and you have them on a nasal cannula, and you go from 3, which is my favorite number to give, okay, to 4, it won't do any good. Okay? You might bump it up to 6, but if they're still having trouble breathing on a nasal cannula, you'll probably have to go up to the next device, like a mask. Okay? Especially if they're mouth breathing. But that's a simple face mask. And like I said, widely used in pediatrics, not so much used in adults just because of economics. And when we look at this non-rebreather, that will let you know that this is why they want to just buy the non-rebreather instead of 2 different masks. The indication, back to the simple face mask, the indication for a simple face mask would be moderate respiratory distress. So you have that patient they're using some accessory muscles. They may have 3-word dyspnea. They're really struggling the work of breathing is up, so they're having to work a little bit to breathe. Okay, so that simple face mask.
Is severe respiratory distress or moderate?
Say what?
Is it moderate respiratory distress or severe?
It's a moderate for the non-simple face mask. I didn't have that up there, but simple face mask is moderate respiratory distress. The non-rebreather, which is the most common, and that does really replace the simple face mask.
Teachers, pardon the interruption, if you sent a student down for a dress code violation, they should return with a pink slip. Students should return with a pink slip. Thank you.
The difference is that you would note between a non-rebreather is the reservoir bag. One of the goals in using a non-rebreather is to make sure that this reservoir bag stays inflated. This is that way they can breathe this pure oxygen here. On this, I don't have one on this particular non-rebreather, so this is actually what would be considered a partial non-rebreather, but there's valves that adhere to the side of the mask. So when they breathe in, the patient breathes in, these valves sort of adhere to the side of the mask, and this valve that's on the inside will raise up, and the patient is breathing primarily, oxygen. the carbon dioxide is cut off with breathing in the carbon dioxide. It's cut off with these outlet valves on the side of the mask. So that when the patient has it on, they're breathed in, these inlet valves will, like I said, pull towards the mask and seal that off, and then this one here will come up and allow the oxygen out of the reservoir bag to come out in the mask, just so you mix less gases. So you're with a non-rebreather mask, you're primarily breathing oxygen, and it doesn't mix as much carbon dioxide. The liter flow is 10 to 15 liters per minute. You can have, I usually start at 10 if that will keep the reservoir bag full. And if they collapse the bag with inspiration, okay, then I'll go up to 15. After 15, you're going to have something different. Okay, you don't have to use a bag valve mask. Okay. If it's over the nose, it clamps there for a good seal. And again, we want to make sure that we keep the reservoir bag at least 2/3 inflated when the patient takes a breath in. Before you place a non-rebreather mask on the patient, you would fill the reservoir bag first. So you'd hook this into the oxygen, hold the valve down, let the reservoir bag fill, and then you'd place it on the patient. Okay? You see it on TV all the time with this on their face with this flattened reservoir bag, right? That's why it's TV. Okay, that would be against your standard of care to put a non-rebreather on somebody without oxygen in the reservoir bag. So 10 to 15 liters per minute, but look at the difference in the FiO2, 90 to 95%. So it's a big difference. It's a smaller gap because they don't mix. We're not mixing gases. We're not mixing that carbon dioxide level. So 90 to 95%, and the indication would be severe respiratory distress. So this patient they're using accessory muscles. Their rate is increased. They're having trouble work of breathing. They're having trouble breathing, and their mouth breathing. And so they would use the non-rebreather mask for that patient. Questions there? Okay. All right. The bag valve mask is the last one I think we have for here. Yep. We would use a bag valve mask for a patient with severe respiratory distress. Add in there pending respiratory failure. So this patient is about to stop breathing. Okay, let me grab a bag valve mask. So severe respiratory distress or pending respiratory failure. So maybe this patient has a rate of 6, right? That's pending respiratory failure. They're about to stop breathing. They're retaining a lot of CO2 and they're about to stop breathing. Or respiratory arrest, they've stopped breathing. Just like the non-rebreather has a reservoir bag that we need to fill up, it takes about 15 liters of oxygen to fill this reservoir bag up. And as we squeeze the bag and release it, squeeze and release, okay, we want to make sure the reservoir bag stays inflated. There's an adult bag valve mask, like we have here, a child and an infant. Okay, so we want to use the proper bag valve mask on the proper patient. This bag, and then you hear a little click in there maybe, the valve and the mask. So bag valve mask, okay, has about a 500 milliliter volume to it. And that equals the approximate tidal volume of an adult. Okay? Tidal volume is the amount of oxygen, approximate amount of oxygen that a person inhales with one breath. So for an average adult, it's 500 milliliters. And so the bag is a 500 milliliter bag. So when you squeeze it and release it, you're administering 500 milliliters are a good tidal volume. That's why there's different size bags, and there's also different size masks that we have. Here, depending upon if the patient's intubated, then you get more towards 100%, but it increases that FO to 95 to 100% with a dose of 15 liters plus, like 15, 20 liters perhaps. Doesn't really take much more than that. So you want to make sure that the bag stays inflated. Those are the oxygen delivery devices. Any questions there? We're good?
You said pending respiratory what?
Failure. Pending respiratory failure. So severe respiratory distress, pending respiratory failure, or respiratory arrest. Suctioning is also part of airway. Okay, so when we look at suctioning, when we broke it down, the other video we broke it down, some of those questions about secretion. So you have a question or you have a patient with a lot of secretions, or they may have vomitus, or they may have blood or something in their airway. So suctioning is part of airway management. When we go to suction a patient, we in a test question, you have a patient that has respiratory distress, blah blah blah, and his airway's full of secretion, so you hear gurgling. Suctioning is the priority, so you would suction that patient before you would start like bagging that patient. You want to make sure that you clear the airway first, so you'd suction. There's a time limit on suctioning. Per the book, about 15 seconds. For an adult, it's less than that. For pediatric, it's closer to 10 seconds for a pediatric. The books vary with the times, but most of them say about 15 seconds for an adult, because what happens with suctioning, it creates a vagal, or it can create a vagal response. It activates the vagus nerve, which drops the heart rate. So either we want to make sure that we monitor the heart rate, either with the EKG or pulse, to make sure that the heart rate's not dropping when we're suctioning, or we just want to limit the suctioning to 15 seconds. Book-wise, test-wise, 15 seconds for an adult, because of the potential of creating a vagal response. When we're doing the skill itself, remember that we suction on the way out. So we leave the suction off. We measure the suction catheter, like a Yonkers or a hard tip suction. We would measure that from the tip of the ear to the tip of the mouth. And then we would go in, and then we would suction for no longer than 15 seconds on the way out. Once we've finished suctioning, then we need to oxygenate the patient, because this is going to cause a little hypoxia. Remember, hypoxia is the lack of oxygen to the cells. Okay? And so to offset the hypoxia, we're going to oxygenate the patient. The suctioning. Most suctions are vacuumed, the powered suctions, and then we have handheld suctions. But it's the same procedure, whether you're doing it manual or electronic. Okay? We suction for 15 seconds, and we suction on the way out. You don't ever lose the distal tip of your suction device. So you always want it, like the Yonkers tip, the hard tip, you always want to keep the distal tip in sight. Okay? And that's one of the benefits of measuring as well. But do watch out for the vagal response. And it's very important in a pediatric patient not to create that vagal response and drop the heart rate. Heart rate is more critical in a pediatric patient than an adult patient. All right, good for airway. Quick sort of fire hose trip through there, but like I said, it's just sort of a review. Let's look at the types of shock. Shock, by definition, is the inability for the body, inadequate. Start over again. The definition for shock is the inability for the body to supply oxygen and nutrients to the cells. So the nutrients would be glucose, and then the inability to supply oxygen and nutrients. It's also known as hypoperfusion. I don't use that very often, but hypoperfusion is the inability of the body to deliver oxygen and nutrients to the cells. So we have shock, and we have these different types of shock. Hypovolemic, hypo meaning volume, all right? And then hypo meaning low, then volemic volume. So hypovolemic, low volume, can either be blood or fluid loss. Keep in mind, pediatrics can go into hypovolemic shock through vomiting and diarrhea. So can we, so can adults. Right? You can have a worst case scenario like with a food poisoning or something where you lose a lot of volume and you can go in hypovolemic shock. It's also known as hemorrhagic shock as far as blood loss is concerned, but hypovolemic shock, hemorrhagic shock, the difference is just hemorrhagic shock is blood loss, and then hypovolemic shock is blood or fluid. Most people just use hypovolemic shock. The other type of shock next one that we have listed is psychogenic. This is like fainting. It's like going to the freezer and realizing that someone has put an empty bucket of Bluebell in there, right? You go and you open the lid and it frightens you so bad that you pass out. Needles, different things, blood. We just talked about phlebotomy, so someone can have psychogenic shock from the sight of blood and they have a syncopal episode or they faint. It's self-correcting. Once the patient lays supine that's fainted, the body corrects the blood pressure problem and their blood pressure goes back up. The other type is cardiogenic, or the pump failure. Most of the time cardiogenic shock is fatal, but we have a pump failure, either through a sudden, maybe congestive heart failure, sudden onset of heart failure, or through an MI, myocardial infarction or heart attack. They have a pump problem. So the pump itself is the problem. The pump is not delivering the oxygen and nutrients to the cells. We have the pump and we have the vessels. Okay, so vessels are working fine. In cardiogenic shock, the pump is not working. In an MI, what takes place, a lot of times you have a large surface MI, and especially like an inferior MI, or the bottom part of the heart, the bottom part of the heart is now infarcted or it's dead tissue, and remember the ventricles pump from upward, they push the blood upward. So if the inferior part of the heart is infarcted and it's a large surface area, then you're going to lose contractility, correct? Through that. And if it's a very large surface, then the heart won't be able to contract at all. But any loss of contractility is going to decrease your cardiac output, because keep in mind the formula for cardiac output is stroke volume times heart rate. So stroke volume is the amount of blood that is ejected during systole or during contraction in each ventricle. So we have, during contraction, the ventricles contract and they eject, on the average for an adult, is 70 milliliters. So the average stroke volume for an adult is 70 milliliters. If we have a large surface MI, then that stroke volume decreases, and we have a decrease in cardiac output, which would decrease the amount of oxygen and nutrients delivered to the cells. The other types of shock that we have is distributive shock. This type of shock has, because of the massive vasodilation, the body has a hard time distributing the blood flow. Hence distributive shock. No volume loss, okay, just vasodilation. The types of distributive shocks that we look at are anaphylactic shock, like from a allergic reaction. You have neurogenic shock or spinal shock from like a spinal cord injury. You have septic shock, right, from like a large bacterial infection or sepsis. Did I forget one? So we have anaphylaxis, anaphylactic shock, neurogenic, and then sepsis, on the distributive shock. We have all these kinds, KINS, that are pushed out into the vessels during these distributive shocks that causes the vasodilation. And then obstructive shock, like in a pulmonary embolism. So you have an embolism that has blocked a pulmonary capillary bed. So you have a PE or pulmonary embolism is probably the most common type of obstructive shock. The key thing in all these, okay, key component is a drop in blood pressure, okay? You will note on a test question that the patient's in shock when the systolic blood pressure is below 100. Okay? The other thing that you will see, other sign that you will see in shock is a sustained tachycardia. So before you have a drop in blood pressure, you're going to have a sustained tachycardia. The body itself is going to compensate by increasing the heart rate. We increase the heart rate, we increase cardiac output. So it's going to try to compensate for that with the sustained tachycardia. And then as we enter into decompensated shock, which I believe is on the next slide. So we have compensatory shock or compensated shock, which the body, through the elevation of the heart rate, is compensating, okay, either for the dilation or the loss of fluid. So it's compensating and it's keeping the blood pressure up. So you don't have a sustained tachycardia, but this patient in compensated shock is going to be normotensive. So their blood pressure is going to remain normal, okay, during compensated shock, but they'll have the increase in heart rate. When the patient decompensates, that's where you see the blood pressure drop below 100 systolic, but the heart rate still stays up. They're still trying to compensate somewhat, but they're in a decompensation period where the heart rate stays up, but the blood pressure begins to drop below 100 systolic. Then you have irreversible shock. That is when the heart rate drops. Now you have a profound bradycardia. Remember, bradycardia less than 60, right? Tachycardia greater than 100. So in irreversible shock, now you have a profound bradycardia and hypotension. So the patient's hypotensive and they're bradycardic, and it's irreversible. There's a lot more physiology that goes into that, dealing with the pre- and post-capillary sphincters, that we will learn during cardiac physiology, but it's irreversible. So you have these different you have these different forms of shock, and then you have the different stages of shock. Our treatments it varies at level to level, okay? One of the first things that we want to do is to keep the patient warm. The body loses or decreases the ability to clot if the patient's not kept warm. So even in North Texas in August, we're going to use warming measures. We're going to cover our patient, okay? We're going to keep them warm. We're going to evaluate the need for oxygen, so signs of respiratory distress, SpO2 less than 94. We're going to apply a high concentration of oxygen. Depending upon your skill set or your scope of practice, we may replace that fluid or fill that vascular space with normal saline, sort of a temporary fix to keep the blood pressure up, okay? It's temporary till we fix the problem. Okay? Or they may administer blood, something to fill that vascular space. In a distributive shock, where there's not any fluid loss and no trauma, we use a medication to cause vasoconstriction. Just mentioned a couple, dopamine or Levophed. They're very powerful vasoconstrictors. So they use the medicine itself to vasoconstrict. And through that vasoconstriction, we have an increase in pressure. Through the replacement of volume, we have an increase in pressure. All these are temporary measures until we fix the problem. So if the patient's bleeding, then we fix the bleeding problem. Okay? If they're in anaphylactic shock, then we fix the allergic reaction problem that they're having, right? Sepsis, we fix the bacterial infection. We start administering antibiotics. We keep the blood pressure up. We administer antibiotics, okay, and fix the sepsis. Any questions there? We're okay? Oh, we'll do cardiac and then we'll take a break. This would be a good place to break off. Acute coronary syndrome, ACS is just a phrase that they use when we talk about cardiac-related chest pain. Okay? So we have this patient, this cardiac patient, and they're having cardiac-related chest pain. It starts out most of the time with this process of arteriosclerosis. When we're young, we have this nice open vessel. There's no pressure problems. There's not a lot of plaque problems. And as we eat more and more bluebell, we move towards building up plaque. This plaque also in these vessels decreases the elasticity of the vessel, so no longer can the vessel expand and contract the way it used to. And also, because as it narrows, it builds up pressure, which could also break part of that plaque off and cause a clot, okay? Like in a coronary artery, where patient would have a potential heart attack, right? So you have this arteriosclerosis is just a process over a long period of time of the narrowing of the artery, where you get over here to the end and you have very little blood flow through there, but you have a lot of pressure and you have a lot of plaque buildup, so it takes away the elasticity of that artery as well. When we look at cardiac-related chest pain, it's different than respiratory chest pain. We'll talk about that probably another day. Right? But you have substernal or pressure that's underneath the sternum or in the center of the chest. A lot of times the patient will describe it feels like someone's squeezing me or sitting on me. They might even say it feels like you're sitting on me. Okay? It's this pressure type pain. when you're assessing this type of pain, it's important that in anything in the chest, any abnormal feeling in the chest, we consider as pain. It's not the type of pain like if I take my golf club and hit you in the shin. Okay, that's a different type of pain. Okay, so you might have patients saying, I don't feel any pain at all, but this pressure in my chest is killing me. That's the same as pain. Okay, so it's that pressure type pain. Feels like someone's sitting on you or squeezing you. The other, it may radiate down the arms or legs, at the back, neck, jaw, both arms, left arm. Typical, it's sort of a classic. So you have this substernal pain, pressure type pain. It's radiating into my arm and back and neck, and then you get short of breath. So you have dyspnea with it, so shortness of breath. Nausea and vomiting's not there, but we also always know when there's nausea, vomiting will usually follow. Okay? Diaphoresis or sweating, and then weakness. The patient feels weak. Weakness comes from they're having this cardiac event and they're not, it's decreasing their cardiac output. So when we look back, pressure type pain, radiating pain in the jaws and back, arms, okay, shortness of breath, nausea and vomiting, diaphoresis, and weakness. When you have about 2 of those, you have a patient that's having a heart attack until proven otherwise. And we'll get into that in a bit, okay? So if they're having pressure type pain and they're nauseated and short of breath, then they're having a heart attack until proven otherwise. So we have those signs and symptoms, and these signs and symptoms are the same whether the patient's having angina or angina, depends on where you live, right? Or they're having a heart attack, they're having an MI. All the symptoms are the same, with the exception of once you start treating the patient for the pain, angina usually goes away with the nitro. Where if they're having an MI, the pain won't subside. So if there's, we'll get into that when we talk about the 2 types of angina pectoris or angina. You have stable and unstable. Stable, remember we made up this story about this cardiac patient. They've been prescribed nitroglycerin. You know, the tablets that patients take, nitroglycerin causes vasodilation and increases blood flow around a blockage or a constriction. And so they have stable angina or predictable angina. So this patient here that has stable angina, when they're out mowing their lawn or they're doing something that's, maybe they decided not to ride in the golf cart that day, they carry their golf clubs, right? And so they're walking along the fairway and they start having chest pain. And it's that pressure type pain. They may get a little short of breath with it, right? But they remember that their cardiologist told them, when you have this exertion, you're going to have this type of chest pain, this pressure type pain, a little shortness of breath with it. So what we want you to do is to stop what you're doing. So stop whatever's causing the exertion, rest, and then take a nitro tablet. Remember, nitro is given sublingual, 0.4 milligrams sublingual, and it causes vasodilation. So it's going to cause the patient vessels, all the vessels, to dilate, which in turn is going to drop their blood pressure. So when you're administering nitro, remember you have to have a blood pressure above 100 systolic before you administer nitro. Okay? But that's stable angina. So this patient, they're out there, they're carrying their clubs for some foolish reason. They start having the chest pain. They go to the bench, they rest a little bit, they pop a nitro, pain goes away. Okay? Stable. Very stable. Predictable. Okay? You have the same patient now that's home watching that exciting, gut-wrenching golf tournament. Right? You just can't hardly, he's standing on the edge of his seat wondering who's going to win, right? But he's at rest. This patient's at rest. There's no exertion here. Or maybe the patient's sleeping. That's if the pain wakes the patient up from a sleep, or there's no exertion, and they start having this pressure type pain, shortness of breath, maybe a little nausea, then it's considered unstable angina, or USA, unstable angina. Okay, so this is a true medical emergency. This patient needs to contact their cardiologist. I recommend that this patient go be evaluated by ambulance, okay, because they're having this unstable angina. So there's no exertion in it. What they're going to do is the same. They're going to take the nitro, they're going to rest, even though they're at rest, they're going to try to rest some more, take a nitro to see if it will go away. With the stable, hypothetically, with the stable angina, I mean, you're looking at, maybe one tablet and some rest. Unstable angina, they're at rest. They take 2, maybe 3. It will go away, but it's unstable or unpredictable. Everybody good with the two different ones? So we have stable angina, unstable angina, and then we have, I just put that up there because I thought it was so cool. Isn't that a cool picture? Yeah, of all the arteries. Now what we have, the next one is someone having an actual heart attack. So in one of these big arteries, like the widowmaker here, that goes all the way down the inferior part of the left ventricle, breaks off and has a clot. So there's a blockage there now. So there's not getting any distal blood flow down through there. What is the time again? 20 minutes before the tissue is dead? Something like that? Okay. So 20 minutes without perfusion, this tissue is going to infarct. So now they have the big clot there that's keeping distal blood flow. So they're having the MI, or acute myocardial infarction, or AMI. The signs and symptoms are the same. So this patient that's having this heart attack or this MI, okay, is still going to have pressure type pain, shortness of breath, nausea, vomiting, radiating pain, diaphoresis. All that's going to be the same. They're taking the nitro, they're resting, okay, but there's no relief. So typically in an MI, the patient's not going to get any relief with the nitrates. To get relief, you're going to either have to fix the blockage or increase your treatment some. Because as you can see on the side, right in here, all this distal tissue from the clot is not receiving blood, so it's infarcting. So this is going to be dead tissue, again, 20 minutes or so. Don't quote me on the number, but I think that's it from the con video. Oh. So this patient here, having this MI, then they would need to go to the cardiac cath lab. They need to go get that that vessel opened up, put a stent in there, remove that clot. Okay. Other things that you might see, okay, it's like we said, the squeeziness or the heaviness, the palpitations. I got palpitations this weekend playing golf for some reason. Okay, my heart sort of, like you guys drink those energy drinks and your heart just sort of like beats out of your chest. That's palpitations, okay? Or a flutter in it. Like I said, radiating down one or both arms. Dyspnea, nausea. The patient will know that there's something wrong here, okay? And so they're going to have this feeling of doom, this anxiety that's built up because they know something's wrong. Okay? Same way with shock. They're going to have this anxiety because they understand that something's wrong with their body. Questions there? Okay. Vomiting. You get irregular heart rhythms in an MI, both tachycardia and bradycardia. It just depends on what part of the heart's affected. And then these abnormal pressures they talk about is if the patient goes into cardiogenic shock. Okay, so if someone's having a heart attack, they could have what's called a STEMI. A STEMI is ST elevation myocardial infarction. ST, which is the ST segment on the EKG, elevation myocardial infarction. So we look at this 12 lead here, and this one's color-coded for us, so we can see the ST elevation in the different leads. So if we look here in lead 2 and 3 in AVF, okay, we see the ST elevation. So when they do a 12 lead on the patient, this is going to show up with the ST segment, which is the segment past the S wave on the EKG and right before the T wave. Okay, so you have the ST segment, and that's going to be elevated. It's going to look like an elevator. So in a second here, we'll have a picture of this J point, but this J point or this ST segment is going to go straight up. That's the way that you know it's elevation. It sort of goes up like an elevator. When we look at a 12 lead, we look for ST elevation in 2 or more consecutive leads. These leads are broke down in like this color chart because you can have a heart attack or an infarction on any surface of the heart. So a 12 lead essentially looks at these different views, okay, looking for electrical disturbances on the in the heart. So 2, 3 in AVF is the inferior, or the bottom part of the heart. The lateral part is the lead 1, AVL, and then 5 and 6. Okay. Eventually you need to know this for the PCT stuff, okay, but not right now. And then anterior, you have V3, V4. So in a STEMI, ST elevation MI, then we'd look for ST elevation in 2 or more consecutive leads. And like promised, here's the J point. So this part right here is the ST segment, and then the J point is the beginning, or where the QRS wave ends, okay, at this point right here. And this J point and ST elevation will go straight up. The difference in here, like on this one at V2, see, this doesn't go straight up, it's more of a slope. So on a 12 lead interpretation, you can get fooled sometimes thinking that this here is ST elevation, but it's more of a slope. And there's a number of reasons why you would have that slope, that it wouldn't be a heart attack or an a STEMI. All right. So they can go in and they can dilate it. They can put a stent in there. They can put a balloon in there. They can do a CABG or a graft that bypasses the obstruction. So there's several different things that they can actually do for someone having a MI. But our treatment, okay, when we look at it, we want to evaluate, do the ABCs always, do our good sample, our OPQRST, get that good assessment going. But we want to do a 12 lead right away to see if it's a STEMI, because you can have a non-STEMI, and a non-STEMI is where there's patients still having the same signs and symptoms as a heart attack, okay, but no ST elevation. But they're still having a heart attack. They're having a non-STEMI. So we want to do a 12 lead. We want to evaluate the need for oxygen. We want to administer aspirin, which is the ASA. Aspirin here is used as an anticoagulant or a blood thinner. Okay, so we want to thin that blood down, okay, so it can get past that obstruction. We administer nitroglycerin, spray or tablet, 0.4 milligrams sublingual. Remembering, though, when we administer nitro, it will drop the blood pressure. You'll be introduced to something called Darcy's Law in cardiac physiology that's going to explain why nitroglycerin always drops the blood pressure. And so it's a vasodilator, the class of medication. And so we're going to administer nitro up to 3 times every 5 minutes. And what this does, it decreases the workload of the heart. On a lot of these medications that we're about to talk about here, it decreases the workload of the heart. So if that patient is having an MI, that's one of the goals that you want to do. You want to decrease that workload, okay, of the heart. It's just the same way with carrying a lot of weight on your backpack, right? So you have a lot of weight. If you're having trouble carrying the weight, you want someone to come along, take some of the weight off of you, so you have to work less. Someone having a heart attack, we don't want that heart muscle working hard and then requiring more oxygen that it doesn't have. So it's a vasodilator, up to 3 doses every 5 minutes. Make sure you check blood pressures in between. We can administer beta blockers, again, depending upon your scope of practice. A beta blocker is going to slow the heart rate down. So if we have a heart rate usually above 70, it'd be a contraindication to give a beta blocker of a heart rate below 70. But if we have a faster heart rate, we may give a beta blocker to slow that heart rate down, block those beta responses to decrease the workload of the heart. And then the last medication is morphine. And beta blockers and morphine are given IV. The nitro is given sublingual. We could give morphine, and the reason that we give morphine is the same. We want to decrease the workload of the heart when we talk about our treatment. And then ultimately, if this patient is having a STEMI or they're having a heart attack, we want to get them to the cath lab to do the stent. All right. Any questions? You guys good? I know that was really quick and a lot of information, but like I said, it's just sort of the first part of the review. Once the next section that we're going to pick up, not today, but the next section that we're going to pick up is we'll start with congested heart failure and move through the respiratory process, okay? Everybody good? Questions?